Thank you so much, Dr. Abdullah, and congratulations on another successful heart failure and focus meeting. My task in the next 10 minutes is to cover recognition, phenotypes, and management challenges in ATTR cardiomyopathy. Do all of that in 10 minutes. So we'll talk briefly about different phenotypes. We'll talk about, touch on heart failure and disease-modifying therapies, and try to give some take-home messages at the end. This is a well-versed audience about cardiac amyloidosis, but briefly, cardiac amyloidosis is a disease that grossly manifests as increased wall thickness. Microscopically is characterized by amyloid deposition in the extracellular compartment, and from an etiological standpoint, the most common form of cardiac amyloidosis is indeed ATTR cardiomyopathy. And TTR is a naturally occurring protein that we all have. The problem in ATTR cardiomyopathy is this tetramer disintegrates, dissociates into monomers, and it is when these monomers unfold, they cannot go back and form the tetramer. So these unfolded monomers start to deposit in amyloid fibrils, and these are the fibrils that deposit in the myocardium and cause all the downstream consequences. ATTR cardiomyopathy is an under-recognized cause of heart failure, and as a result, there is a delay in diagnosis. Between onset of symptoms and initiation of therapy, there is usually a median of 3 years. Think about that. 50% of patients take more than 3 years to reach a diagnosis and start on treatment, and by the time they are diagnosed, they are usually have a more advanced degree of organ involvement, predominantly cardiac involvement. Why is that? It's because the manifestations of ATTR cardiomyopathy are system-wide. It's not a purely cardiac disease, and that's why we need guidelines to help us think and diagnose this problem. But this is a slide that shows the American and the European guidelines. And if you think this looks simple, think again. Look, you have to think about a variety of red flags, and you have to follow different steps to reach the diagnosis. Even if we try to simplify it and think about disease red flags, rule out plasma cell abnormalities, perform cardiac imaging and confirm cardiac involvement, the problem is that the red flags are multiple, and they involve different organ systems. And in my opinion, this is the step where disease delay in diagnosis happens. Once you think about amyloidosis, the pathway is easy. You perform plasma cell abnormality workup, you perform cardiac imaging and confirm cardiac involvement. It's about suspecting the disease. That's why I tried to come up with 4 phenotypes that you must think about cardiac amyloidosis every time you encounter a patient that fits one of the following 4 phenotypes. Not all of them will end up with cardiac amyloidosis, but there are high-yield subgroups that thinking about cardiac amyloid and ruling it out is worth your time. So number 1, HFpEF with LVH. You may have heard me before say this. If you encounter a patient with heart failure and LVH, pause and think about cardiac amyloid. It may end up being amyloidosis, but more likely it will be something else. But you've given the patient the opportunity and the benefit of the doubt. So this is an example. This is a patient who was admitted with exactly that. First heart failure admission, unexplained left ventricle, borderline troponin elevation. The diagnosis was initially missed. When you pause and you start to look at the pieces that are available, no additional testing. We just looked at the tests that were done. Unexplained LVH, apical sparing pattern on GLS, low voltage. This is enough to go to the next step, which is to perform cardiac amyloid radionuclide scintigraphy, which confirmed the diagnosis. Next, you rule out a plasma cell disorder, and you have a diagnosis. And this patient was diagnosed with wild-type ATTR cardiomyopathy and was started on a disease-modifying agent, which happened to be a stabilizer in this case. So LVH with heart failure with LVH, think amyloid. Phenotype 2, patients with recurrent HFpEF admissions. I'm not saying all of them will end up being amyloid, but you need to exclude amyloidosis in this phenotype. This is a patient that I admitted 83-year-old female admitted with heart failure, AFib and RVR. If you look back in our records, she had 4 or 5 heart failure admissions in the preceding 4 years. She was admitted in our Center of Excellence, treated by our heart failure team, and we did not think about cardiac amyloidosis. She also happened to have CKD and hypertension. She had troponin elevation and BNP elevation out of proportion to the degree of volume overload. She also had progressive leg weakness. It's only when I suspected and when we suspected cardiac amyloid that we went back and asked about these symptoms, which turned out to be a spinal stenosis. Again, we're just looking at the available information. We're not ordering fancy testing to come up with this diagnosis. She was sent for PYP or bone avid radiotracer scintigraphy, and we confirmed the diagnosis. Unfortunately, the patient became very sick, developed advanced renal failure, was started on dialysis, developed sepsis, and unfortunately did not make it out of the hospital. That tells you that when we miss these patients and we miss the diagnosis, these patients progress and we miss an opportunity to change their trajectory. Recurrent heart failure, HFpEF admission, think amyloid. The third one is patients with severe aortic stenosis. Not every patient with aortic stenosis has cardiac amyloidosis, but it is worth a while to think about cardiac amyloid and screen these patients. Not all of them, you have to find enough red flags. This is a patient that came to our center for TAVR, and it turned out that they have the low flow, low gradient variety. That is a red flag and that warrants further investigation. Again, if you look at available testing, this patient turned out to have discrepancy between LVH and ECG, which led to subsequent testing, and he turned out to have apical sparing pattern and turned out to have amyloidosis. And what happened to this patient? He received TAVR and a stabilizer. So a disconnect or disproportionate ECG, apical sparing pattern, abnormal cardiac biomarkers, RVH are some red flags in aortic stenosis that warrant further workup. And the last one is bilateral carpal tunnel syndrome. Anytime you hear the word bilateral carpal tunnel syndrome, especially if you see patients in their advanced years of age, you have to think about cardiac amyloid. This is a patient that we discharged from our hospital with heart failure, and he was told no need to follow up with cardiology, came to see me to renew a lipid prescription, and he has bilateral carpal tunnel syndrome. Went back and I found that he has elevated biomarkers, low voltage ECG. He was referred for CARI, and he was found to have TTR. Every time you hear bilateral carpal tunnel syndrome, it is reasonable to think about cardiac amyloidosis. But why does it matter? Because there are things that we can do to these patients and we can help change their trajectory. Amyloidosis is a multidisciplinary disease. You have to refer them to a center of excellence. The backbone of their treatment is decongestion with loop diuretics. You have also to use GDMT rationally. You know how we always say 4 pillars, 4 pillars. These patients, you have to think first before you start them on GDMT. SGLT2 inhibitors and MRAs have a promising role, and there is a variety of disease-modifying therapies available, and we are very fortunate in UAE that we have access to 4 disease-modifying therapies. There are 2 oral medications that are TTR stabilizers, tafamidis and acoramidis, and there are 2 injectable medications that are TTR gene silencers that are currently available, vutrisiran and eplontersen. And eplontersen, the results on the CardioTransform, which is the largest cardiomyopathy clinic, are coming up in the next couple of months. So how do you decide which patient receives which? I think it all depends on insurance, availability of medication, and your personal expertise. If there is a patient that prefers oral medications, you better use silencers. If they cannot take oral medications, or if they prefer 3 times or 4 times a year injection, then you send them for an injectable. So in conclusion, ATTR cardiomyopathy is a commonly under-recognized cause of heart failure. HFpEF with LVH, recurrent HFpEF admissions, bilateral carpal tunnel syndrome, severe aortic stenosis, always think ATTR. Decongestion is the backbone of treatment for these patients. They need to be on disease-modifying therapies, and there is a promising role for SGLT2 inhibitors and MRAs. And lastly, you have to think about DOACs. We didn't have a time to discuss, but these patients are at least risk for thromboembolism. Thank you so much.
Excellent.